Hi, this is Nursing It. Today we're going to discuss key concepts in immunity and regulation of the immune system. Inflammation and immunity go hand in hand. Our immune system serves to protect us from disease and pathogens that cause illness. The inflammatory response is part of the immune system and provides an immediate response to endothelial and tissue injury or damage, as well as foreign pathogens, so basically illness or injury. Your immune system recognizes pathogens by the proteins on the cell membranes. So our body's immune system can recognize me versus not me based on the proteins that are on the surface of the cells. Lymphocytes and T cells work with immunoglobulins to provide us with general immunity, while white blood cells release things like histamine, heparin, leukotrienes, serotonin, and bradykinins to trigger the inflammatory response, and that causes capillary leaking and third spacing and all sorts of swelling. Our body also acquires specific immunity to pathogens by developing memory cells, and that's a specialized lymphocyte cell. This adaptive immunity can be acquired through natural processes like having a disease like chickenpox or receiving memory cells from the mother through the placenta or breast milk. Or the immunity can be acquired from artificial measures such as vaccinations or antibody injections. Active immunity means that you make your own antibodies, and passive immunity means that they are passed on to you or they're given to you. So natural active immunity means that you made your own, you acquired the immunity from having the disease and developing an antibody to it. Natural passive immunity comes from your mother who passed it on to you. So it's given to you through a natural process. So breast milk or through the placenta in utero. So the antibodies then are passed on, and those are natural antibodies that the mom had. Active artificial comes from your body actively making your own immunity to a vaccine. And so the vaccine could either be an attenuated dose, so not strong enough to cause disease, or it could be an inactivated disease. But basically the proteins are still on the cell membrane. And so your body recognizes it still as foreign, not me, and makes memory cells so that if you were ever exposed to it again, you could fight it off. A lot of times our body can only remember things for a certain amount of time, and so you might need a series of exposures to create adequate immunity, and then you might need boosters later on to continue that immunity. So artificial immunity is not typically as effective as natural active immunity. And then artificial passive immunity we use when someone has had an exposure, like post-exposure prophylaxis, where we do antibody injections. And we do that for things like rabies and tetanus. And with that, since you're injecting the antibody and not the antigen, you're not making memory cells. Allergic reactions occur when there's an inappropriate immune response. Both the inflammatory and immune responses are activated, resulting in pruritus, which is itching, urticaria, which are hives, seen here, and possibly angioedema, which is swelling of the lips, tongue, and the periorbital areas, so facial swelling. Allergic reactions can be localized or diffuse, but typically just involve the skin, sometimes a little GI. They're best treated with antihistamines, which block that histamine response, that inflammatory response, And other medications that we use for allergies include things like leukotriene inhibitors and mast cell stabilizers. So again, that's all working on that inflammatory response. Patients with chronic or more severe allergies may also benefit from immunotherapy or allergy shots, which help desensitize the immune system. Sometimes our memory cells get us into trouble. Anaphylaxis or anaphylactic shock is the most severe type of allergic reaction. The response is systemic. It involves 2 or more body systems with this exaggerated immune response. Remember, histamines cause capillary leaking. They also cause mucosal edema and this excessive mucus discharge, as well as the pruritus and the urticaria and the angioedema, which you see here. In general, the faster the onset of the anaphylactic reaction, the worse the reaction will be. Typically, every time you're exposed to the same allergen, the reaction will be faster and more severe if you're developing a hypersensitivity to it. However, delayed reactions up to even 6 hours after the exposure can occur. So if someone uses like an EpiPen for a bee sting, we typically watch them for about 6 hours in the ER to make sure that it doesn't rebound or they don't have a delayed reaction. Look for the allergic reaction skin signs as well as those systemic signs like the hypotension, the bronchospasm, and or GI involvement. Epinephrine is the rescue medication for anaphylaxis. Steroids and antihistamines, H1 and H2 blockers can help with symptomatic relief, but Epi is life-saving. Anaphylaxis is a type 1 allergic reaction, which is mediated by IgE. And if you can remember IgE, then you can remember epinephrine as the treatment. The adult dose is 0.3 milligrams, and the pediatric dose is 0.15 milligrams. Ideally, that would go intramuscularly rather than subcutaneously, because there's better blood flow to the muscle than the subcutaneous tissue, so the onset of this life-saving medication would be faster. This is an EpiPen that you see here. It is an auto-injector meant for the vastus lateralis, so kind of the anterior lateral mid-thigh. If you happen to hit the rectus femoris, you're going to be okay. But it needs to go in that kind of anterior lateral aspect. EpiPens come with a trainer, so they come usually in a 2-pack with a trainer. And the big thing that we want to do is provide the patient or the parent or the provider education on the use and the signs and symptoms of a reaction, and to practice with it. So you really want to encourage them to take out the trainer, not the EpiPen itself, and to practice with it. So if the time comes to use it, they feel empowered and comfortable triggering the device. Epinephrine degrades in light and heat, so it should not be left in a car. It should not be stored in areas that are not temperature controlled. You should keep 2 devices with you at all times in case you use one and then you need a second dose while waiting for help. Check the device to make sure that it's not expired. Look at the device for clarity of the drug and keep the cap on until you're ready to use it. Again, look at that needle. The most common error that we see with the EpiPen is that in times of panic, people hold it backwards and they put their thumb over the end and fire these into and through their thumb. So practice with the trainer is really important, and don't put that needle through your thumb. This should only be used for anaphylaxis. So in times of need, signs and symptoms of a severe allergic reaction, difficulty breathing, difficulty swallowing, full body hives, sensation of throat closing, things like that, then they could use it. They should, again, inject it into their anterior lateral thigh. Follow the instructions carefully on the EpiPen itself. Do not inject into your thumb. It is on a kind of spring-loaded device, so it should be held for adults for 10 seconds before removing, and the EpiPen Junior takes about 3 seconds to finish. That needle does not retract, so you're going to have this big sharps afterwards, so handle that carefully. And then as soon as you deploy an EpiPen, you should call 911. In contrast to acute anaphylaxis or acute inflammation and immunity, some patients experience chronic inflammation. We call these diseases that triggers the body's immune response autoimmune disorders because our immune system has accidentally created those memory cells and antibodies against our own tissues. When the body is constantly at war with itself, it does not have adequate resources then to fight off invading pathogens. Patients with autoimmune disorders are inherently at increased risk for infection. Additionally, most autoimmune diseases are treated with immunosuppressant agents, which deplete the immune system even further. Rheumatoid arthritis, seen here, is a chronic progressive disease that primarily affects the synovial joints, but it's truly systemic. It involves all connective tissue, including blood vessels and organs. Early on, the patient has like morning stiffness of the joints with some swelling or puffiness in the joints. And as the disease progresses with this chronic inflammation that leads to calcifications and adhesions within the joints that cause this severe deformity that you see here. If the C-spine is involved, it can actually lead to instability of the cervical spine and subluxation, so like the vertebrae slip off of each other, which then can pinch or even sever the spinal cord, leading to like paralysis or quadriplegia or death. So monitor neurofunction really carefully in patients who have rheumatoid arthritis, especially if you know that they have it in their neck. And again, monitor patients receiving those immunosuppressant drugs like methotrexate really carefully for infection. Rheumatoid arthritis is associated with other syndromes also, like Sjogren's syndrome, which is everything gets dry, so dry eyes, dry mouth, vaginal dryness. It's also associated with fibromyalgia syndrome. Fibromyalgia syndrome is a chronic pain syndrome that is not an anti-inflammatory process, but it's often related to lupus or rheumatoid arthritis. Patients typically complain of 3 months or longer of things like persistent headaches, fatigue, and burning pain at trigger points. These are most commonly found in the upper back, neck, upper chest, the trunk, the low back, and along the extremities. It's a muscle tenderness rather than joint pain as the presenting complaint, and it may be related to the brain being unable to process pain correctly in the hypothalamus and the thalamus. Signs and symptoms of fibromyalgia often increase in response to stress, activity, and weather. Systemic symptoms include GI symptoms like pain, heartburn, constipation, and diarrhea. GU symptoms like burning, urgency, frequency, and pelvic pain. Cardiovascular symptoms like shortness of breath, chest pain, and dysrhythmias. And then neurological and sensory symptoms like blurred vision, dry eyes, forgetfulness, and concentration problems. Fibromyalgia most often affects women ages 30 to 50, and it might be triggered by things like Lyme, chronic fatigue syndrome, trauma, and flu-like illness. Medication therapy, things like gabapentin, Cymbalta, Savella, tricyclic antidepressants, and trazodone may be helpful for some patients. Physical therapy and NSAIDs are also helpful, and we should encourage the patient to increase activity as tolerated, and regular exercise like walking is really important. Lupus has two types. Discoid lupus, which only affects the skin and has like this butterfly rash, and then systemic lupus erythematosus, which has skin, renal, cardiovascular, pulmonary, neurological, GI, musculoskeletal, and systemic manifestations. It's characterized by exacerbations and remissions of the autoimmune process, which also results in vasculitis like rheumatoid arthritis, and it causes hypoxia to the tissues and the organs. The leading cause of death from lupus is actually nephritis, so damage to the kidney from the disease. The butterfly rash is the predominant presenting factor, and it gets worse with any irritation to the skin, like sunlight and heat. Hydrochloroquine, which is an anti-malarial drug, decreases the absorption of ultraviolet light by the skin and decreases the risk for skin lesions in patients with lupus. Steroids and immunosuppressant medications increase the risk of infection, but also may help in preventing the exacerbation or controlling the exacerbation of this autoimmune disease. Teach the patient about self-care. Cleanse the skin with mild soap, such as ivory. Dry the skin with patting rather than rubbing. Apply a lotion, something that's like unscented, to dry skin areas liberally. Avoid powders and other drying agents such as rubbing alcohol. Use cosmetics that contain moisturizers and SPF 30 or higher. Avoid direct sunlight or tanning beds, any UV rays. Wear long sleeves and a large brim hat outside to protect yourself from the sun. Inspect your skin daily for open areas and rashes, and monitor your temperature if you feel sick. Promote rest and monitor for infection are two of our big things with patients during a flare-up. And then again, steroids could be topical or they could be oral. It's important to taper off any oral steroids that you've been taking for more than 10 days or so to avoid an Addison-like crisis. The last autoimmune connective tissue disease that I want to talk about is Scleroderma or systemic sclerosis, and that also causes what's called CREST syndrome. So this is a chronic inflammatory autoimmune connective tissue disease that causes both fibrosis and then sclerosis of the skin. The patient will complain oftentimes of arthralgias, so joint pain, and then multi-system failure. Malnutrition and weight loss are common, and auto-amputation of the distal digits is possible. Steroids and immunosuppression are sometimes helpful, but smoking cessation is really critical in patients with scleroderma. So calcinosis are calcium deposits in the skin, and they can lead to nodules. Raynaud's phenomenon is spasms of blood vessels in response to cold or stress, and sometimes calcium channel blockers like nifedipine are effective in managing Raynaud's. So we see poor peripheral circulation with Raynaud's. Esophageal dysfunction can cause acid reflux and decrease in motility of the esophagus, which causes the patient to have dysphagia and makes them really high risk for aspiration. So remember with patients with Scleroderma and Crest syndrome that you want to have them sitting bolt upright. So full Fowlers or high Fowlers is bolt upright for meals. So 90 degrees up in the chair if you can get them up in the chair, and otherwise straight upright in bed. Sclerodactyly is thickening and tightening of the skin on the fingers and the hands. And tightly stretched skin can occur anywhere. So this can occur on the face, it can occur on the hands. That's normal. So that's an expected finding as part of this disease process. And then telangiectasias, which are dilation of the capillaries causing red marks on the surface of the skin. So we get those dilated surface vessels. Additionally, they can have shortness of breath, and they can have renal failure and proteinuria. So we're looking at kind of the Crest syndrome with additionally some shortness of breath and renal failure, leaking protein into the urine. So switching gears, I just want to finish up our discussion on immunity, talking about the human immune deficiency virus, or HIV. This virus enters the body through contact with blood and bodily fluids. Routes of transmission include sexual contact, sharing needles or needle sticks, childbirth, and breastfeeding. Once inside the body, the virus enters the body's own immune cells, called CD4 T cells, and replicates. The body's immune system cannot see the foreign protein because HIV hides in the person's own cells. This is why it's been so hard to treat. As the virus replicates, it kills off the body's immune cells, decreasing the CD4 count, causing systemic effects like fatigue, poor wound healing, weight loss, and fever. This places the patient with HIV at risk for opportunistic infections. These are the overgrowth of normal flora when the immune system is depressed by medication or illness, or the ability to get sick when exposed to something that someone without HIV or immunosuppression could be exposed to and not get sick. Common HIV-related opportunistic infections are things like tuberculosis, pneumocystis jirovecii, which causes pneumonia. This is a fungal pneumonia. Toxoplasmosis, so exposure to cat boxes can cause encephalitis. Cryptosporidium can cause really severe GI illness and diarrhea, and severe weight loss and dehydration, electrolyte imbalances, acid-base imbalances. And candidiasis, they can have really significant overgrowth of candida, of yeast, and they can get candida albicans, oral thrush, bodily yeast infections, vaginal yeast infections. Common HIV-related malignancies are Kaposi's sarcoma, which is seen here. These are skin and mucous membrane lesions that are kind of brown. And then lymphomas, both Hodgkin's and non-Hodgkin's lymphomas. And they're much higher risk for cancer related to HPV, so specifically cervical and anal cancers. Acquired immune deficiency is the syndrome that occurs when the CD4 count falls below 200 cells per microliter in the patient with HIV. A normal CD4 count is 800 to 1,000 or even 1,500. Even if this CD4 count improves, once the diagnosis of AIDS has been assigned, it is not reversed. AIDS is associated with increased complications such as opportunistic infections, malignancies, and AIDS wasting syndrome. And this is considered kind of the terminal phase of the progression of HIV. HIV is managed with prevention of infection. Teaching the patient with HIV about infection prevention is really important. So trying to avoid those opportunistic infections as well as other infections. That includes kind of the standard precautions that you would teach somebody who is immunosuppressed from chemotherapy or who is on chronic steroids or immunosuppressants. Avoid crowds or people who are sick. Do not share personal care items like, toothbrushes, things like that. Avoid raw or undercooked food. Don't drink any standing water or liquids. Do not change the litter box and avoid turtles and reptiles. Monitor for and report fever, cough, open wounds, or any signs and symptoms of infection. Take your medications as prescribed and have your routine blood work followed carefully. The most common medications that we use for HIV management include the nucleoside reverse transcriptase inhibitors, and then the non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, fusion inhibitors, and entry inhibitors. And typically, people aren't just on one medication, they're usually on multiple or on one of the combination medications. So currently, most people are on some form of a combination medication. We also want to talk to our patients about their safe sex practices. So condoms and dental dams are really important. Even latex gloves for any, hand, finger contact. And then water-based lubricants always, even when using condoms, to make sure that the condom doesn't break and that there's no tears in the skin that could lead to bleeding, even if it's just microscopic. For the patient with a high-risk lifestyle who does not have HIV, but who has sex with people who are HIV positive, there are medications available for pre-exposure prophylaxis. Combined with safe sex practices, these are effective at decreasing the transmission of HIV. Truvada for PrEP is one of these medications. This is a combination drug. It's 1 tablet daily, again for high-risk populations. It begins working after the 4th day of consecutive use, but it's considered ineffective if 2 consecutive doses are missed, and it won't be effective again until they've done 4 days consecutively after those 2 missed doses. It's important to monitor renal function while you're taking Truvada, and people who are taking medications for PrEP have to have their HIV status tested every 3 months and continue to use those safe sex practices. So again, condoms or dental dams, some sort of barrier device with a water-based lubricant to avoid even just microscopic tears or fissures, and then even, gloves for any finger or hand contact. And then monogamy also is important for pre-exposure prophylaxis. They find that the fewer partners the person has, the more effective PrEP is. As always, thank you so much for watching. I hope that this is helping and that you all are surviving nursing school. It's almost over. Kudos to all of you for hanging in there in this crazy 2020 spring semester. And I wish you the best of luck. Thanks.